So, good afternoon, one and all, to this vast session to discuss a few must-have skills and toolkits for ophthalmologists. Basically, these are very basic skills needed by every ophthalmology in our daily practice, and we hope you may be able to refine your techniques after seeing this session. So, myself, Dr. Gargi Satish, I am Additional Professor, Government Medical College, Kottayam. The moderator for the session will be Dr. Padmashri. She is Associate Professor, Government Medical College, Kottayam. And the convener, Dr. Anita Prabhakaran, is a Senior Consultant in Precise Eye Hospital, Trivandrum. The panelists for the session are Dr. Biju John, a favorite professor for so many of us sitting here. He is a renowned vitreoretinal surgeon and Professor of Ophthalmology, Paripalli Medical College. Dr. Deepa M.G., Associate Professor, Government Medical College, Kochi. Dr. Nishi R.S., Assistant Professor, Government Medical College, Kottayam. Dr. Arya R. Gopi, Assistant Professor, Kottayam Medical College. And Dr. Sri Lakshmi, she is Senior Resident, Government Medical College, Kottayam. So, going straight to our session, over to Dr. Padma, the first topic.
Thank you, Gargi Madam. My topic for presentation today is posterior subtenon injection, anesthesia and more. An injection into the eye is a very fearsome experience to a patient. But we as ophthalmologists know that it is very difficult to deliver a drug into the eye. So when we think about a subtenon injection, whenever we need the drug to be present in the posterior segment of the eye, and to go into a relevant anatomy a little, Tenon's capsule is a fibrous membrane that extends from the posterior aspect of the globe to fuse anteriorly with the conjunctiva slightly posterior to the corneoscleral junction. It is closely applied to the globe but may be lifted for some distances. You can see here at the equator, the subtenon space is narrower and posteriorly it is a little more wider. And this is a subtenon space into which you are injecting the drug. Indications for a subtenon anesthesia would be a posterior subtenon anesthetic injection and indications like delivery of steroids into the space in conditions of non-infectious uveitis and cystoid macular edema due to different various causes. And in some conditions like for anti-cancer therapy also this modality is used. So what for an anesthetic injection, what armamentarium you need is nothing more than the usual instruments like a tooth, the forceps and a Westcott scissors and anesthetic loaded in a 5 ml syringe. Attached to a regular hydrocannula or a subtenon cannula, which is a smooth curved cannula, which it will be more preferred. And the injection can be given more anteriorly, about 8 millimeter, with different kinds of subtenon cannulas of the various lengths. But posterior injections are better because the drug goes into the posterior intra and extracorneal spaces, and you get good anesthesia with small volumes of a drug with low risk of chemosis. So regarding the technique, after painting and draping, this is the inferomedial conjunctival fornix that is being dissected. Now the video is upside down. That is why it is the inferomedial fornix. You have to avoid the insertion of medial rectus and lateral rectus. After opening the conjunctiva and the tenon tissue, you have to identify the sclera, then inject the drug. The drug, initially you inject a little amount of volume and then you can complete the injection by giving the whole volume. Up to 3 to 4 ml you can give with slow injection, and within few minutes you will get good anesthesia. Now the next procedure with this posterior subtenon is a periocular steroid injection. So that was classically described by by Nozick by around 1960s, and supratemporal site was the described one. And supratemporally we can give it with a cannula for a safer as an alternative, and in uncooperative patients you can opt for a transeptal orbital floor injection. So in this video I have made the patient lie down, otherwise normally it is just required to make the patient sit with a with a head leaning towards the backrest. But here, for video purpose, I have made the patient lie down, anesthetize the conjunctiva with local anesthetic drops and with a speculum for better exposure. And for a safer technique, I have also used the limbs forceps to hold the conjunctiva, and then with a 26 gauge half-inch needle fitted to a tuberculin syringe loaded with a drug, 1 ml of the drug is injected to the subtenon space. So you have seen that the movements of the needle is checked with horizontal to and fro movements, and if you see the same movement of the needle with the globe, then you may have the tip of the needle might have engaged the sclera. So that should not happen. You have to be careful. Freeman and associates have shown that this technique of supratemporal injection had placed the drug more accurately near to the macula, and so this is a very good technique, alternative to intraarterial injection and an office procedure. So but there are certain dreaded complications which can happen if these things are not attended to. That is globe perforation, because you are going with a 26 gauge sharp tip needle. You are going with a needle. This globe perforation, always there is a risk. So another risk is a central retinal artery occlusion, which is very, very rare, unless because we are going into this subtenon space, which is not vascular. But always rule out any. You should not inject. When it is injected into the vessels, it can lead on to vessel occlusion, embolic occlusion, and can happen. Minor problems like a subconjunctival hemorrhage or a conjunctival swelling can happen as a complication. So the alternative technique to avoid globe perforation is a supratemporal cannula method, where you can use a 22 gauge standard intravenous cannula instead of your needle. All complications of steroid injection can happen. This is not per se due to the technique. So what are the safe practices in a posterior subtenon injection? Careful patient selection, ensure correct placement of the needle, follow contour of the globe, use a blunt tipped instrument like a cannula, and slow injection. So what are the limitations for the procedure? Previous extensive vitreoretinal surgeries, repeated strabismus surgeries, eye trauma, orbital infections are all like relatively, they are all almost absolute contraindications. So what is the take-home message I have for you is master the technique. It is a very safe and painless OP procedures, and in the upcoming era of nanotechnology, this may be one of the preferred techniques. So it is better to master it, and thank you for your patient hearing.
Thank you so much, Dr. Padma. That was an excellent demonstration of posterior subtenon anesthesia, which she is actually a master of PST, and it is very useful when you are converting from peribulbar block to topical in the middle. Anytime you can give a posterior subtenon and supplement the anesthesia. And a PST steroid is definitely a very safe procedure in the correct hands. As he said, we can even give it to children. They can be very cooperative if you are very skilled in giving a PST. So over to the next topic. I invite Dr. Anita Prabhakaran.
A very good afternoon to one and all here. At the outset, I would like to thank this IC team and KSOS for having given me an opportunity. With the newer definitions of dry eye syndrome and a better understanding of it, it necessitates for us to get a good practical insight as to the various aspects of the tear film, like instability, hyperosmolality, inflammation, etc. And therefore, we need to, there comes the importance of doing the various tear function tests. A very healthy precorneal tear film is very important in many aspects, especially because it is the primary refractive surface which determines the optical quality. As we all know, it's a trilaminar layer The aqueous layer constitutes the major constituent middle part, which actually has a role in the defense. It lubricates, it supplies oxygen, nutrition, waste removal, etc. But it is attached to the hydrophobic ocular surface by the microvilli of the mucin layer, which is the innermost layer secreted by the globulate cells, and the outermost layer, lipid layer, helps it in the stability and resist its fall against gravity by its surfactant effect, and that is secreted by the meibomian glands. So tear film analysis can be classified based on whether to check about the quantity of the tear, quality, tear volume, etc. Or it can be classified like aqueous, mucin or lipid deficiency. So let's see one by one. Schirmer test is a very common test which is done in our practice. We need to first wash our hands thoroughly and then switch off the fan and the AC so that there is no evaporation of the tears from the environment, and preferably to bend the Schirmer strip within the cover itself so that we don't touch it, and insert it into the lower lid. Ask the patient to look up in the junction of the medial 2/3 and the lateral 1/3. Either the patient can keep the eyes closed or can blink normally. Wait for 5 minutes, remove the strip. The normal value should be somewhere around more than 15 millimeters. If it is less than 10 millimeters, is supposed to be dry eyes and in 5 minutes time. We can mark it with a pen and then stick it with the transparent tape onto the patient's file as well. The Schirmer, as we all know, has a Schirmer 1A is by without instilling any topical anesthesia. It measures both reflex and basal secretion, whereas if we instill a drop of anesthetic agent, we can measure the basal secretion. The Schirmer 2 is by doing by stimulating the nasal mucosa. There was a test, Schirmer 3, done before by looking into the sunlight, but that is no more practiced. John modified it by multiplying the 1 minute value of Schirmer. So we need to keep the Schirmer paper only for 1 minute, and value multiplied by 3 gives a 5-minute value. There are several disadvantages of the Schirmer test, the most important being the discomfort caused to the patient and the potential injury to the ocular surface. So to eradicate that or to rectify that, we have this phenol red test where we can use only a very small thread or a thin thread which will not cause any discomfort to the patient. As it is impregnated with the dye, we can easily read the values as well. The next test to analyze the tear film stability is the tear breakup time. We instill a drop of fluorescein, we instill a drop of fluorescein and we ask the patient to blink few times so that the fluorescein gets spread thoroughly, and then we ask the patient to stop blinking. We start the stopwatch or count it. We measure when the first dry spot, the black spot appears. So the time lapse between the last blink and the first dark spot is the tear breakup time. Again, if it is less than 10 seconds, the tear film is unstable. If less than 8 seconds, it is supposed to be diagnostic of dry eyes. But we have to know that installation of fluorescein itself will affect the stability of the tear film, and therefore the non-invasive breakup time is supposed to be the most reliable method to denote the tear film stability, and it can be done with various instruments like keratometer, hand keratoscope, tear scope, etc. In our center we have this ocular surface analyzer which actually gives us a very good picture or very easy way of doing an NIBUT, and that is all these instruments, they project a concentric rings onto the corneal surface, and the time lapse between the last blink and the first distortion of the image is what is noted. As we can see in the video on the right side, the distortion of the mire on the lower side can be noted, and that is because of dry eyes caused by poor lid approximation. As we can see here, the lid is not getting approximated fully. The one test to identify the tear volume is the tear meniscus height, otherwise known as marginal strip or tear lake. Normally should be somewhere between 0.2 to 0.7 millimeter. And as said, it's very small volume and the tear is also transparent. And the method to do, this is what we need to measure. The method to do it is actually by making the slit horizontal and measure over the middle part of the lower lid with the patient looking at the primary gaze, and measure with the width of the slit beam. But again, that will be seen better, appreciated better with a fluorescent stain. So that again affects the tear volume. So ASOCT is one method. Otherwise, we have this analyzer which gives us a very good value. We can just read the value very easily from the chart. Okay, next is 80 to 86% dry eyes is because of lipid layer deficiency. So a very good meibography to identify the morphology and the structure of the meibomian glands is very important. This machine also does that by if we can evert the eyelids, and we get the very quantitative analysis is also obtained by this machine. It has its own software scoring system called a Meibo score. And one more method is by interferometry. Interferometry, it also measures the thickness of the lipid layer in between blinks, and the blink dynamics is also measured, and finally it gives us a report like this with which the color coding is also there. So it is very easy for us to diagnose and also grade the severity of the dryness, and we can treat accordingly. Ocular surface staining has been done from we have always been doing it, and we all know that interpalpebral staining and lower one-third staining of the cornea by fluorescein is supposed to be diagnostic of dry eyes. And lissamine green and rose bengal are vital stains which have a double triangle sign as they stain the interpalpebral area. Rose bengal is the better tolerated one, and they can be graded as well. Conjunctival impression cytology by pressing the tissue paper at various quadrants, and that gives us an indication as to the loss of goblet cells and keratinization. These help in identification of the mucin layer deficiency. How to get an idea of the dynamics of tear film? It's by fluorescein clearance test. That's by using Schirmer test and fluorescein, and wetting and disappearance of the dye is measured every 10 minutes. And with that value, we calculate the tear function index, which is Schirmer test with anesthesia divided by the tear clearance rate. If it is less than 96, it denotes dry eyes. There are several other tests like tear osmolality using a freezing point depression osmometer, normally should be somewhere between around 300, and MMP test, lactoferrin test, blood test for the anti-SS antibody to diagnose if there is Sjogren syndrome, tear fern test, tear scope, etc. So with all these tests, we can get a very comprehensive idea about what kind of dry eye it is, and about the quality and quantity and various other aspects of the complex composition of the tear film, which helps us in a better modification of our treatment and much happier patients. Thank you very much.
Thank you, madam, for that exhaustive presentation. It is very difficult to cover this topic in 6 minutes. And madam has included all the conventional techniques along with the newer advances in each. And that was very good presentation. And in our clinical practice, most of our patients will be presenting with the symptoms of dry eye and abnormalities of tear film, but we may not be going through all these tests. Only one clinical scenario where we are made to do this is the Sjogren syndrome. Patients are referred to our ophthalmologist for assessing the tear volume. So that is a test that we usually do. All the other tests are more of academic interest, and also PGs doing paper, they will be doing all these tests and going behind patients. Okay, so we will move on to the next topic. I will call upon Dr. Arya for presenting incision and curettage and supratarsal injection.
A very good evening to all. My topic of presentation is incision and curettage, and second topic is supratarsal steroid injection. So the main indication for incision and curettage is calasion, which is a benign lesion. Usually it is sterile, and it is a lipogranulomatous inflammation of meibomian gland. And so the initial line of management is always conservative, and it includes warm compression, digital massage, and usually antibiotics not required since it is sterile. And if antibiotics needed, it is in severe blepharitis and associated rosacea. So coming to the topic proper, the prerequisites for my procedure are calasion clamp, curette, and conjunctival scissors and forceps, and number 11 blade, and other things like topical anesthetics and lignocaine, adrenaline, etc. So before the operation, you have to consider following things. You have to take a proper history and carefully examine the lid swelling and rule out other causes of lid swellings like atypical lesions which may mimic a calasion. And always locate the lesion, whether it is within the tarsal plate or anterior or posterior to it. Then after confirming the diagnosis of calasion, we can go for incision and curettage. So you have to do the investigations like viral markers and routine blood sugars, and a preoperative blood pressure can be monitored. And after getting an informed written consent and a drug sensitivity test, and ruling out all other contraindications for the procedure, you can go for the surgery. So these are the atypical lesions which may mimic a chalazion, or meibomian gland carcinoma, tuberculous mass, leishmaniasis, and in immune conditions like Kaposi sarcoma and hyper IgE syndrome, there may be swelling which is similar to chalazion. So always rule out such condition, because in such cases INC is not the procedure of choice. We have to do an excision biopsy and a microscopic analysis is needed. And always you have to suspect a malignancy in a case of recurrent chalazion which is recurring in the same location, or usually in old age patients. Now coming to the topic proper, first you have to instill the topical anesthetic drops and identify the chalazion and where it is exactly located. You can mark it with a pen. Then clean with the povidone iodine solution, and after sterile draping, 2% lignocaine with adrenaline can be infiltrated in the subcutaneous in the cutaneous approach. Then gently give a massage for 1 minute. Now our instrument chalazion clamp is placed in position over the lid swelling with the open blade over the conjunctival side. So usually we will have a conjunctival approach. So in conjunctival approach, you have to put a vertical incision. In some cases, this chalazion may get infected, and this purulent material can get collected in the anterior to the tarsal plate area also. So in such cases, you can put a skin incision, which is usually horizontal, to avoid the scarring. Now, after putting the vertical incision, curette out the contents using chalazion curette or scoop. Now always make sure that you have to break down all the loculations within the chalazion cyst and wipe around the sac until all the debris is cleared. And if the cyst wall is visible and it is very thickened and fibrous, you have to excise the cyst wall. Now after doing the procedure, we can remove the clamp, and no need for suturing. The hemostasis can be achieved by applying pressure and a pressure pad and bandage. Patching can be given for 6 to 12 hours. So this is the procedure. So after cleaning and draping, we are giving an local anesthetic infiltration to the area where the chalazion is located. Usually lignocaine with adrenaline is given, 2% lignocaine. Give a gentle massage. Now placing the chalazion clamp. Now verting the lid with the chalazion clamp in situ. Now using a number 11 surgical blade, you are putting a vertical incision. Now curette out the contents using a chalazion scoop. Now the chalazion contents are scooped out. Have to break the all loculations within the sac, gently wiping around the sac. Now the cyst wall is excised using conjunctival scissors. Now the clamp is released and eye is patched. So in the post-op period, only we have to advise the patient to continue the warm compression and antibiotic drops. Usually we will advise oral antibiotics for 5 days, and we can follow up the patient after 1 week. And the possible risk and complications are, usually patient may rebleed. after the procedure and present to us. And the main complication is it may recur in the same site if we are not doing the procedure properly, or if the callosine contents are still retained. And the long-term complications are scarring and lid notching. Now before coming to the second topic, supratarsal injection, I also want to mention about the intralesional steroid injection, which is also a treatment modality for calasion. Here the drug used is triamcinolone acetonide, which is the dose is 10 mg per ml, which is about 0.2 ml is given, which contain 10 mg per ml, and we can give the injection through the skin or conjunctival side. Now, usually we can advise this intralesional injections to the calasion which are undergoing, which can be done with an INC. So here the most common indications are multiple small calasion, and usually the calasion which is adjacent to puncta, which is not amenable to INC, because INC may damage the lacrimal apparatus. So in such cases also intralesional steroids can be advised. And also chronic calasia, after undergoing repeated INC, if it is not resolving, we can advise an intralesional steroid injection. So this is the procedure. You can give the injection in the cutaneous area. About 0.2 ml of triamcinolone acetonide, which contain 10 mg per ml, is injected into the subcutaneous plane. Okay. Okay. So the possible complications are the steroid-related complications, most commonly IOP elevation, steroid-induced ptosis, subcutaneous fat atrophy, skin since it is given through the skin side, it can cause depigmentation of the skin. Conjunctival side, it can cause conjunctival necrosis, and the common thing is recurrence. It may recur, so you may need repeated injections. So so both INC and intralesional steroid injection, both are a treatment modality. We can combine these two in a case of large or multiloculated calasion. So coming to the second topic, supratarsal steroid injection, the common indication is recalcitrant VKC, which is usually presented with giant papillae, cobblestone appearance, shield ulcer, and limbal gelatinous nodules. So the drug is triamcinolone acetonide, which is preservative free. The dose is 20 mg, which is equal to 0.5 ml. We can give 0.5 ml for each lid. Usually it is a bilateral condition, we can give 0.5 to each lid. So the site is 1 millimeter above the superior tarsal border, in the potential space between conjunctiva and Muller's muscle. So usually we approach through the conjunctival side. The pre-op consideration, you have to get a consent, and IOP recordings is must, because we have to rule out steroid.
You can go to the video, Arya.
Okay.
You have that.
Okay, madam. So after the procedure is, after cleaning and draping and topical anesthesia, triamcinolone acetonide is injected into the subconjunctival conjunctival side 1 millimeter above the superior tarsal space. So only topical anesthesia is needed in this procedure. Some may prefer lignocaine anesthesia. After putting topical anesthesia, you can inject 0.5 ml of triamcinolone acetonide, which contain 20 mg, 1 millimeter superior to the tarsal border, upper tarsal border. So this is the procedure. So post-op regimen, you have to discontinue the topical steroid and continue the topical antibiotics and olapatidine drops. IOP monitoring is must in the post-op period. So the symptomatic relief will take within a few weeks. The complications are glaucoma, eyelid necrosis, subcutaneous fat atrophy, and usually recurrence is a common. Thank you.
Thank you very much, Arya. That was a very nice presentation. Though you couldn't fast forward the video, that's the reason for the delay, the prolongation, it's okay. Very commonly done procedure, very easily done procedure, but gives a lot of relief to the patient. And especially as you mentioned, we have to always keep in consideration whether there's any other lesion which we are missing, especially when it is recurrent in the same area. Therefore, send it for a biopsy. Whatever material you're curating out, but send it for biopsy, right? Yeah, that's really a very good presentation, and supratarsal injection as well, usually done. The next one I would like to invite is Dr. Nishi RS. She would be telling us, talking about a very important topic on corneal scraping, which is an essential tool to identify the microbe or the in the management of corneal ulcer. Therefore, I invite Dr. Nishi for the next talk.
Good afternoon to everyone. I'll be discussing on corneal scrapings. So basically, it is done for two indications. One is diagnostic to know the etiological agent causing the infection. Another is therapeutic, that is to debride the necrotic material, especially in case of fungal keratitis, to help the penetration of the drug also. Now the requisites, we require a local anesthetic, proparacaine is preferred, and for the scraping we can use a 26 gauge needle, half-inch needle, or a 15 BP blade, or a Kimura's spatula. And the requisites to take the scrapings are glass slides. Usually, ideally, 2 slides are taken. One is for the gram stain, another is for the KOH wet mount. And the 2 plates are taken for culture. One is for the bacteria, that is the blood agar. Another is for the fungal, that is a Sabret's dextrous agar. Now, the procedure, ideally, most important thing is to inform the patient regarding the procedure so that the patient as such is comfortable, take an informed consent. Once the patient is reassured, it will ease the procedure, and the patient won't blink, because blinking is one reason which causes contamination of the scrapings from the lid or the lashes. So the local anesthetic proparacaine is preferred because it is the least microbicidal one, and you can wait for some time, ideally 1 minute, and you can repeat the anesthetic, topical anesthetic if required. But we always have to remove the excess anesthetic that is there in the conjunctival sac prior to this. So collection of the sample, the first step is to remove the purulent material or debris that is lying around the infiltrate initially, because we don't want it into the scrapings. So that can be done with a sterile cotton bud. And the next step is to scrape the edges in the base of the infiltrate. So usually in moraxilla and all is found at the base. So in those cases, please concentrate on the base. Otherwise, always the advancing edge is scraped more, and ensure that you make unidirectional strokes, that is in the same direction, avoiding areas of thinning. And once the samples are collected, you have to transfer it to a pre-marked sterile glass slide. So if it is pre-marked with a glass marker, it is easy for the microbiologist to identify the place where we have taken the smear. So the slide that is taken should also have an identification name or the number of the patient, and as thin a smear as possible should be made with when making a gram stain. With KOH, a freshly mounted 1 drop of 10% KOH is put on the slide, and then we take the scrapings and immediately cover it with a cover slip and send it for examination. If you have a fluorescent microscope, you can even use calcofluor white for staining. And if you suspect any mycobacteria or nocardia, you can take 1 more extra slide for AFB. And if HSV keratitis is suspected, we can also do a PCR. And when you take the cultures, ideally when in the blood agar culture, we should make superficial strokes on the plate in the shape of a C. Multiple strokes are made, and for the Sabret's dextrous agar, the blade is directly dropped into the media and sent for examination. Now, if acanthamoeba is suspected, you may have to use 1 more extra media, that is the non-nutrient agar enriched with E. coli. And if liquid media is used, you have to swirl the medium. Now, there are certain special situations, probably we'll have to go for other modalities like local anesthesia and all, other than topical anesthesia, especially in case of uncooperative patients or pediatric patients or highly uncooperative people. In highly uncooperative, even GA may be required. So when there is thinning, probably a GA might be required, like in desmetosine and all, to lower the IOP. And if the infiltrate is very deep-seated, probably you may have to trephine, get a small piece, cut it into 2, send for one piece for histopathology, another for microbiology. And if another method is to raise a flap and to scrape the deep infiltrate. Now this is the video. Actually, I think, yeah, initially you have to use a sterile cotton bud. This is to remove any debris that is lying on the surface of the infiltrate, or to remove the excess local anesthetic or tear that is there. so that you get the proper base on which you will do the scraping. So meanwhile, the patient is also very well educated. The patient is also cooperating even without a speculum. They don't blink. And now we can use either 26, any of the three mentioned things, like the 26 gauge needle. Here I am showing this video where the scraping is taken with a 26 gauge needle. So you can see that the scrapings are always done in the same direction. One single unidirectional movements of the needle is important. And we scrape from the base as well as the active edge of the ulcer. And the material that we get will be used for the staining, gram stain, KOH, as well as for your cultures. See, this is the KOH being taken onto the pre-marked area of the slide. There it is marked. There is a small round area that is marked beneath. And then you place a drop of KOH, freshly prepared 10% KOH. Then you take the, transfer the scrapings onto this. And then immediately you have to cover it with a cover slip and send for examination at the earliest. Now I have one more video where I show the scrapings being done with a 15 gauge BP blade. If time permits, I'll show you. This is the next one. Here actually the scraping is done with a 15 BP blade. The procedure is the same. You have to remove the debris, excess tear film and all using a sterile cotton bud. And after that, meanwhile you are educating the patient so that he is confirmed that he is informed that it's not a painful procedure and that the patient has to cooperate. So now this is the 15 blade. You can always, you should be careful when you're scraping with the blade. Again, it's a unidirectional movement of the blade from the active edge of the ulcer. Here in this ulcer, the leading edge is towards the pupillary area. So we are scraping from the active edge as well as the base using the 15 blade. So you have to exert moderate pressure. So it neither should be too low or too high. So it is a moderate pressure that we use to do the scrapings. And in this, I am showing the scrapings being used for the culture. So when you take the culture media, it's better to keep the lid on the table, so that the lid, if you take it and keep it back, you might contaminate the lid. So it is better that the lid is kept on the surface. You take the culture media in your hand and take the scrapings. So once you place it back, the chance of contamination is minimal. And you can even tape the edges of the plate, label it, and send it back for examination. This is the Sabret's Dexus agar, into which you can drop the next. It is a fresh blade that we take for this, and the scrapings are directly dropped into the media and closed. Actually, we are using sterile gloves, and so the chance of contamination is minimal. So it is immediately closed, sent for examination. I think it is a very simple procedure which can be done with caution. Thank you.
Thank you so much, Nishi. That was a wonderful presentation, lots of videos. And corneal scraping is an art in itself. There are a few madams and sirs whom I definitely scraping we will get something on the microbiology, whereas if we scrape it too superficially, so I usually take the patient to those people so that the scraping is done so excellently as an art that definitely if there is a fungus, it will appear on the KOH. So it has to be perfected, and communication with the patient is very much needed, and it is actually requiring quite a lot of skill and communication skill, especially a communication skill with the patient also. Thank you so much. Inviting Sri Lakshmi to talk about preparing fortified antibiotics.
So a very good evening to all. So I am talking about fortified antibiotics. basically what is antibiotic, what is a fortified antibiotic and how it is prepared. So fortified antibiotics are prepared by adding the required amount of parenteral agent to an artificial tear solution or to a commercially prepared topical solution, which is a preservative-free solution to treat corneal ulcers. Most of the available normal topical antibiotic eye drops gives only a subtherapeutic concentration in the corneal stroma. So it is better to give fortified antibiotics in special conditions like moderate to severe ulcer, endophthalmitis, postoperative and traumatic drug-resistant corneal ulcers, and avoid unnecessary usage of fortified antibiotics to prevent multi-drug resistance. So we usually prefer combination therapies. Empirically, we start first generation cephalosporin and aminoglycoside to cover both gram-positive and gram-negative bacteria. Once the culture and sensitivity report comes, we can change our antibiotic accordingly. So just a word about dosing. Loading dose is 1 drop every 15 minutes for 1 hour to achieve the corneal overload. Then 1 drop every hour alternating every 30 minutes for the initial 48 hours. Then treatment is given every 2 hours slowly tapered according to clinical response. Coming to topic proper, preparation of commonly used topical antibiotics. So how to choose antibiotic? So we can choose antibiotic to which the organism is susceptible to. So this is a table showing the susceptibility to the various organisms to antibiotic. So gram-positive cocci usually respond to vancomycin. The topical concentration is 50. Gram-negative organism, both rods and cocci, they respond to ceftazidime. The same topical concentration as vancomycin 50. Nocardia and non-tuberculous mycobacteria they have separate antibiotic drug of choices. Like nocardia, we can use amikacin or cotrimoxazole, and non-tuberculous mycobacteria, amikacin, clarithromycin, azithromycin are used. So these are the commonly used antibiotics. Ceftazidime, that is the topical concentration is 50 mg per ml. We usually we can either add 20 ml or 2 ml. We usually do is we can add 2 ml of artificial tears to a vial of ceftazidime or artificial tears or sterile water. Then we take 1 ml from that and we dissolve into 9 ml of artificial tears, so that we get a final concentration of 50 mg per ml. Ceftazidime injection comes as 1 gram powder. So vancomycin, it is a same dosage 50 mg per ml because it comes as a 500 mg powder. So we can directly add 10 ml of artificial tears and we can use directly the whole solution can be used as topical fortified antibiotic. Tobramycin or gentamicin is slightly different because we add the commercially available injectable vial, that is 40 mg ml, the 2 ml vial, the whole 2 ml, that is it contains 80 mg. The whole 2 ml is added to the tobramycin or gentamicin ophthalmic eye drops that is available, and so that we get a final concentration of 14 mg per ml solution. This is a table downloaded from the American Academy. The contains commercially available amount and volume of diluent and final concentration. Coming to specific drugs, cotrimoxazole, especially we already said used for nocardia. IV preparation is used directly as eye drops. Amikacin indicated in atypical mycobacteria and nocardia, especially after LASIK procedure. Clarithromycin is an excellent drug for refractory atypical mycobacterial keratitis, but it is highly irritant, so we usually don't use it. Then azithromycin indication is chlamydia and chlamydia. It has high tissue bioavailability and EHAF of 2 to 4 days, so less dosage is needed and has potent anti-inflammatory activities. Linezolid, it is only for vancomycin resistant intolerant gram-positive keratitis. It has better tissue penetration, even it can penetrate the intact epithelium. Then colistin, we all know it is used only in multi-drug resistant pseudomonas. It's a short video showing preparing fortified antibiotic. Ophthalmologist herself is preparing the fortified antibiotic under sterile aseptic precautions. She's first showing the injection vial, vancomycin vial, then sterile bottle, artificial teardrops, emptied bottle of antibiotic, syringe and needle. She's cleaning the vancomycin injection vial. Then she's taking the whole, since she is preparing fortified vancomycin, she is taking the whole 10 ml artificial preservative free artificial teardrops. Then the whole thing is injected into the vial. Then shake it, shake well. Then take the 10 ml, whole 10 ml, and we can divide it into 1 ml and 9 ml. 1 ml can be added to the empty bottle, antibiotic bottle, and can be given, it should be labeled properly and given to the patient. The rest whole amount is we can label and refrigerate for the next day use, so that we can give daily fresh fortified antibiotic drops for the patient. Labeling is very important. Just a few seconds more. So labeling should contain the patient name, date and the name of the drug. It should be refrigerated. Okay. That's all. Thank you.
Thank you, Dr. Sri Lakshmi, for that excellent presentation of a very dry topic, but she presented very well. It's a very important topic, and as she said, the antibiotic use has to be very rational, because antibiotic resistance is coming up, and we have to be very careful in using our armamentarium of drugs. So initially, but in ophthalmology practice, in endophthalmitis and all, we have no choice other than giving initial broad spectrum, covering all the possible organisms. But later on, after your when you get your microbiology reports, then you have to shift on to your specific antibiotics. So the topic was very relevant and very important as practicing ophthalmologist. So let us move on to the next topic. I invite Dr. Deepa to present her topic, yak capsulotomy.
Well, because I am very tall and not visible from behind the podium, I thought I'll move slightly to the sides. Thank you, the IC team and KSOS for the opportunity. And at the very outset, I would like to apologize to you all, because in a video-assisted skill transfer, I am not having a video. My video had a last-minute glitch. Please bear with me. And I believe that in yak capsulotomy, it is the patient selection that is the most important rather than anything else. So this is a very common procedure that we all, in the beginning of our career, if there is one procedure which we feel at ease with in doing without any tension, it might be a yak laser capsulotomy. Let us all rewind and refresh our knowledge about this very common procedure in ophthalmology. So ND-YAG laser, neodymium yttrium aluminum garlet, is the laser that we use. It is a solid state laser with a wavelength of 1024 nanometer. And how it acts is producing an optical breakdown, which leads to ionization and plasma formation, and that leads to an acoustic wave production, which leads to tissue disruption. That is the mechanism of action. Now, what are we breaking with this laser? It is a posterior capsular opacification that is formed by the proliferation of the epithelial cells. On top of it, there is addition of contractile fibroblasts and collagen deposition, which leads on to the opacification of the posterior capsule. And with an incidence as high as around 28 to 43%, it's a very common late postoperative complication after cataract surgery. The incidence is said to lower with increasing age, and also in phacoemulsification, the incidence is comparatively lesser. There are different techniques. We all know how to reduce this. That is to ensure a thorough cortical wash, to put the IOL properly in the bag, to align the convexity of the IOL, then having a good rhexis margin, smaller than the IOL optic size, etc. Then the material of the IOL. Then the different appearances. These are all theory points which you all know. Then when is it that we do a capsulotomy? The answer is very simple. When the posterior capsular opacification is causing a reduction in the visual acuity and function, or both. But be sure that the reason for the reduced vision is a PCO and nothing else. That's the only point that you have to keep in mind. And in any procedure, our teachers always say we should know when not to do a procedure rather than knowing when it is to be done. So what are the conditions in which you are not supposed to do a capsulotomy? Is when you don't have a very clear view, when there's a corneal edema, when the fixation of the patient is very poor, when the patient is having an intraocular lens made up of glass, when there is a chance or you suspect the patient is having a cystoid macular edema, or he is having a risk for developing retinal detachment. In the pre-evaluation, what we basically do is we assess how thick is the opacity and whether the capsulotomy is absolutely needed. This can be done mainly by how far we are able to make out the retinal findings on a fundus evaluation. You can look at the fundus with a 90D lens, then red reflex evaluation, all can be done. Now in the preparation part, you have to discuss in detail to the patient what the procedure is, why we are doing it and what we are expecting at the end of the procedure, and then get an informed consent. The comfortable seating of the patient is very important. It's just like putting the patient on a slit lamp, but you have to explain that they'll hear the sound sometimes and they should not shift the head. Then after proper comfortable seating, the head has to be strapped. Then the lighting should be comfortable to the surgeon who is doing preferably a semi-dark room. Then sometimes the choice of using a lens is optional depending upon the surgeon's choice. Then providing a fixation target also for the fellow eye of the patient. As I already told, you can use an Abraham lens or not. Some advantages are it improves the converging angle and also decrease the area of laser on the posterior capsule. But the precaution that you should be very careful in using the lenses to avoid laser passing through the peripheral cardial portion of the lens, leading on to a retinal damage. We start with minimum amount of energy of 1 to 2 millijoules per pulse. The shots are placed on tension lines so that with the small burst itself, the break happens along the tension line, which will slightly enlarge. We should always try to follow the cruciate pattern of doing a capsulotomy and also try to avoid larger flaps and the round can opener style of doing a capsulotomy. The advantages of a cruciate pattern is that it starts from the periphery. So if at all an IOL pitting or something happens, it happens in the periphery. And also you have the advantage that the gravity will pull the flap down and you'll have an inferiorly based flap, which will avoid patient getting floaters later on. So this is the cruciate pattern in which a capsulotomy is done. So the first burn will be applied superiorly at 12 o'clock. Then you move, the burns shots are applied towards the inferior part 6 o'clock. Then on either side to 3 and 9 o'clocks. Sometimes a can opener round style is also done in some cases. But preferred one is cruciate technique. So how can we avoid pitting or marks on the IOL is by using minimum energy. And if the patient is not fixing properly, always use a contact lens for fixation. And identify the areas where the IOL capsule separation is there and following a Christmas tree pattern if you are feeling that you are going to get IOL pitting. That is, instead of going to 3 and 9 o'clock, you go from 7:30, go to 7:30 and 4:30 after doing the superior and inferior shots. Now, what should be the size of the capsulotomy? Ideally, it should be the size of the pupil in normal lighting conditions. Then if it is a thick membrane, even the a smaller opening will work wonders. That is what study says, because it has a tendency to expand around 30% a few weeks later. But if it's a very thin and a hazy capsule, the results may be suboptimal. The aftercare is by giving a beta blocker to reduce the IOP. Measure the IOP at 1 hour, especially in high-risk patients, and if the IOP is high, give anti-glaucoma medications. If there is a significant post-procedure iritis, you can give topical steroids. The results are very good, around 96%, and non-improvement is usually due to pre-existing causes. What all can go wrong is an IOP elevation, a cystoid macular edema. In high-risk patients like myopes, pre-existing vitreoretinal problems, they can even develop a retinal detachment. Sometimes there can be incidents of endophthalmitis. Then there can be IOL pitting, as already mentioned before, and other complications like a persistent iritis, macular hole, or sometimes even corneal endothelial cell loss. So this is a procedure, very simple and easy, which guarantees a good visual outcome to the patient when done properly. Thank you for your patient listening.
Thank you very much, Dr. Deepa. It was an excellent presentation. In spite of not having a video, we could get a clear idea about the YAG capsulotomy. But sometimes we get into a dilemma when there is a small, the FR is dull and then there is a small PCO as well. So whether to go ahead with the YAG or whether to attribute the diminution of vision to the diminished foveal reflex. So I think DDO comes a long way in helping us make a decision. So a distant direct ophthalmoscopy, look at the red reflex. If the red reflex is significantly less in one eye, preferable to go ahead with YAG capsulotomy. Of course, with a guarded visual prognosis, we have to mention to the patient. Thank you very much again, and our next and final talk of this session is by our dear Dr. Biju John, as mentioned, the favorite professor of RIO, now professor in Paripalli. So his talk will be on YAG laser hyalodotomy.
Yeah, thank you very much for those beautiful words. I mean, I've been really appreciate selection of these topics, small topics which is of everyday use, but generally these videos are not shown. So I really congratulate the Kota Medical College and the organizers for this instruction course for selecting this. So my topic is YAG laser hyalodotomy. So this is a minimally invasive laser treatment option in the treatment of relatively fresh subhyaloid hemorrhage. I mean, you cannot do it for all hemorrhages. It should be relatively fresh subhyaloid hemorrhage. And best results are attained in cases of Valsalva retinopathy, Tersen syndrome, trauma. Patient with diabetic retinopathy generally doesn't work that easy. When successfully applied, it can affect the drainage of the blood into the vitreous cavity, thereby resulting in rapid improvement of the vision. So the type of the laser used, we have got the Q-switch neodymium YAG laser, the same one which Dr. Deepa was talking about earlier, and the double frequency neodymium YAG laser, which we usually prefer. So the patient preparation is like any other laser procedure. You have to have the consent. A good mydrias is important. Anesthetizing the conjunctiva, positioning the patient. The patient should be comfortable. The surgeon's comfort. I mean, nobody really talks about that, but that is also very important. So using the Q-switch MD-YAG laser or 1064 nanometer laser. Now, how to select the location? Now, where do you apply the laser? It should be away from the fovea and the major blood vessels. Usually toward the inferior edge of the hemorrhage, but not exactly at the edge, because there should be sufficient amount of hemorrhage between in front of the retina, so as to protect the retina. So you need to select a area which is slightly above the inferior edge. And that 4-point aiming beam of the YAG laser is adjusted for anterior focus so as to avoid the retinal damage. Now, ideal size, less than 3 disc diameter hemorrhage, it is risky. More than 10 disc diameter hemorrhage generally doesn't work. So this is the ideal size between these two. You generally use an area centralis lens or a Mainster focal or grid laser lens for doing this. As far as the parameters are concerned, you can start at 1.5 millijoules and it is increased by 1 millijoule increments till you get a perforation and the blood drainage into the vitreous becomes evident. Now, it's considered unsafe and useless to go beyond 12 millijoules because you should know when to stop. Now, another, this is the thing that we generally prefer, usually due to the logistic, because we generally don't have the other YAG laser in our retina clinic, so we generally use for this one, which is we have readily there, that is a double frequency ND-YAG laser or the 532 nanometer laser. Now, this is a photocoagulative laser, so there's a method by which this is changed into a photodisruptive wavelength. You just need to decrease the spot size and increase this power slightly so that large amount of power is delivered to a small area so as to produce a disruptive effect. So the spot size selected is about, usually 50 to 100 microns. The duration is 50 to 100 milliseconds, and you start at 200 milliwatts and gradually increase till a disruption occur. Now, there is another slightly different way by which we do is in a two-step procedure, especially when it is a subhilar hemorrhage because you've got two membranes there. So we start with a large spot size of 300 microns and power of 150 milliwatts and duration of 120 milliseconds for 3 shots. Now this produces slight photocoagulative power so that the membrane or whatever over it is stretched. And due to the stretched membrane, we can now apply a photoreceptive focal laser, a single shot in the center of the above area, the photocoagulated area, which is size 100 microns, the power 150 milliwatts and duration 100 milliseconds to produce a disruption. So this is a video. We don't have a video attached to our laser. So I borrowed it from somebody who has my name. And this is actually recorded by Dr. Biju using his do-it-yourself retinal cam. So you can see it has already been an attempted laser. You can see a few laser spots here, but it didn't work. So here the laser is being, it's working. So you can see that shot there. So there is one shot, so it's already disrupted. So it has selected an area above. That is third shot. So you can see the blood draining from that area. And this is the second day where you can see the rest of the blood is also slowly draining. You don't get an immediate the drainage of the entire blood. So it takes some time. So you can just give it time for about 1 week. This is the first day after the hyaloidotomy. So half of it is drained. So it is draining from 3 sides there. So maybe by a variable period from about 1 day to 7 days, all of the blood will probably drain. Now the complications, which is more common with the 1064 nanometer wavelength, is of course accidental retinal damage, then vitreous hemorrhage if you happen to hit one of the blood vessels, and also anyway there will be vitreous hemorrhage because of when you drain the subhyaloid, it pours into vitreous. Then macular hole formation sometimes, formation of epimacular membranes, especially if it is a subhyalum hemorrhage. Thank you.
Thank you so much, sir, for that highly enlightening talk. I didn't know all this about the double frequency. I usually thought only the Sada ND-YAG was used. Thank you so much. So we shall wind up this session. I think we are near our time also. The next group is waiting to start their session. Hope some skills could be transferred to all who heard the session. Thank you so much.